All right, so a very good evening to everyone. I welcome you all to this particular YouTube session being conducted specially by Arise Medical Academy. So I am myself Dr. Rajesh Guba. I'm the General Medicine Educator for Arise Medical Academy. So in this session, I will be discussing the clinical based questions along with the images as well. So these particular sessions have been specially designed in order to see that you should not face any difficulties in your upcoming FMGE exam. In the upcoming FMGE exam, you're going to have lot many clinical based questions. So in order to crack the clinical based questions, we at Arise Medical Academy have designed these sessions specially. And these sessions you will have every day until before the day of your exam. So please try to utilize these sessions, and this time you should definitely clear your FMGE exam. Now, let us start with the first question. So we are having Mr. Hensley, who is 72-year-old man with only a history of hypertension, and for hypertension he is taking hydrochlorothiazide. And he presents today with acute excruciating knee pain, right? So he is a known case of hypertension. And why he has come to you now? He has come to you with a history of knee pain. On examination, his knee is warm, mildly edematous, swollen, and tender to touch or passive movement. So within the knee, you have all the signs of inflammation, right? That is what is the description which has been given in your clinical based question. Microscopic examination of the joint fluid is shown in the figure. What is Mr. Hensley most likely suffering with? Acute bacterial joint infection, antibodies to anti-nuclear antigens, hyaline cartilage degeneration, increased production of inorganic pyrophosphate, uric acid overproduction. So yes, who will be the first person to answer this question? So this particular history of hypertension, and the patient is on the thiazide group of drugs. This is a very, very important history, right? So this patient is on hydrochlorothiazide. So that's a very important history. Yeah, so please answer. Who will be the first person to answer this question? So, yes, no one want to make an attempt of this question? Right, now let me tell you the answer and as well as the explanation. So the answer to this question is uric acid overproduction. Right, the answer to this question is uric acid overproduction. Now, what is that you have in the knee? Right, so what is that you have within the synovial fluid examination? So you are having the presence of the crystals, right? So these particular crystals, right, they are needle shaped crystals. So what is the condition where you have the presence of needle shaped crystals? You will have in the synovial fluid the needle shaped crystals in the clinical scenario of gout or gouty arthritis. Sorry. So this gout or gouty arthritis, it is characterized by uric acid overproduction, right? It is characterized by uric acid overproduction. Now, the other important point here is, how will you differentiate the other options? How will you differentiate the other options? First of all, what is the point in favor of your gout or gouty arthritis? Presence of negatively birefringent needle-shaped crystals in synovial fluid examination is very much suggestive of gout. Second important point, he is also having a risk factor. What is the risk factor there? The risk factor is your hypertension and the patient is on thiazide diuretics. So an individual whoever is taking this thiazide group of diuretics, there is high risk of hyperuricemia. Right, there is high risk of hyperuricemia. So the answer here is uric acid overproduction. Now let me tell you a few points about your gout. Yes, Mukesh Pal, what is that you are unable to see? Yes, what about others? Everyone is able to see the session, see the image, see the question? Okay, now let me discuss few points related to your gout or gouty arthritis. So if you take your gout or gouty arthritis, it is a clinical condition which is characterized by hyperuricemia. And this increased uric acid levels in your gout is due to either increased production of the uric acid or decreased excretion of the uric acid. Yes, Anzifa, what, you are not able to see the slides? Yes, Mukesh Pal, are you not able to see the slides? Because we have some students answering the question. Arya Ajesh has attempted to answer the question. Okay. So your gout is due to increased production of the uric acid or decreased excretion of the uric acid. Ultimately, the uric acid levels will be increased. Now, in case of your gout or gouty arthritis, the most common joint which is affected, it is your first metatarsophalangeal joint. This is the first joint that is affected. But in our patient, what is given, the knee pain is there. In our patient, it says that, the question says that the knee joint is affected. It's okay, fine. Knee joint can also be affected in your patient with a gouty arthritis. But the most common joint which is affected is the MTP, that is metatarsophalangeal joint. Okay. Now another important point in case of your gout or gouty arthritis is you should know what are the risk factors for your gout or gouty arthritis. Right, risk factors for your gout or gouty arthritis. The very important risk factors are your drugs. And which group of drugs will increase the uric acid levels? Thiazide group of diuretics, pyrazinamide, which is an anti-tubercular drug, then cyclosporin, which is an anti-neoplastic drug, then we have ethambutol, next excessive consumption of alcohol. So these are the risk factors for your gout or gouty arthritis. And among all the risk factors, our patient is taking thiazide diuretics, hydrochlorothiazide. That is one of the risks for the development of your gout or gouty arthritis. Now, in the treatment of the gout, okay, in the treatment of the gout, what is the treatment what we give in the gout or gouty arthritis? So we have the treatment divided into acute and as well as chronic. In acute cases, we give NSAIDs, colchicine, then we have steroids. So these are the drugs which can be given in acute attack of gout or gouty arthritis. Whereas in case of chronic form of your gout, we have two groups of drugs. One, xanthine oxidase inhibitors, so these xanthine oxidase inhibitors, these are the drugs which will inhibit the uric acid synthesis. Right, these are the drugs which will inhibit the uric acid synthesis. And what is the example of this xanthine oxidase inhibitors? They include allopurinol and as well as febuxostat. Right, allopurinol and as well as the febuxostat. And the other group of drugs which are given in the chronic form of gouty arthritis is the uricosuric drugs. Right, uricosuric drugs. Now, what are your uricosuric drugs? The uricosuric drugs, like what we have is probenecid. Right, probenecid. Then we have benzbromarone. And as well as sulfenpyrazine. Right, sulfenpyrazine. So these are the treatment options like what we have for your treatment of gouty arthritis, acute attacks and as well as the chronic attacks. Okay, and we also have a second line agent for your gouty arthritis. The second line agent is your pegloticase. Pegloticase is another important drug that can be given in your gout or gouty arthritis. Okay, so that completes the discussion of why it is your gout or gouty arthritis. Now you take the other options. Acute bacterial joint infection. In acute bacterial joint infection, what does the synovial fluid examination should show? The fluid examination should show the presence of WBCs. Right, the synovial fluid examination should show the presence of WBCs, which is not there in the image which is given to you. And antibodies to your anti-nuclear antigen, you will see that in patients with the SLE, systemic lupus erythematosus. And hyaline cartilage degeneration, you will see this in case of the osteoarthritis. And definitely our patient is having all the signs of inflammation, and the synovial fluid examination is showing the presence of needle-shaped crystals. So your hyaline cartilage degeneration is completely ruled out. Now, you take the increased production of the inorganic phosphate. You will come across this in case of pseudogout, where you have the presence of rhomboid-shaped crystals. Right, where you have the presence of rhomboid-shaped crystals. That is what you will see in case of. And this rhomboid-shaped crystals, which we call it as CPPD crystals, that is calcium pyrophosphate dehydrogenase crystals. Okay. Now let me show you that pseudogout crystals. Yes. So these are your rhomboid-shaped crystals. Okay. So which is nothing but your CPPD crystals, that is calcium pyrophosphate dehydrogenase deposition, and that you will see in case of pseudogout. That you will see in case of the pseudogout. Okay, right. So the answer to this question now is your uric acid overproduction. Right, uric acid overproduction. So now what is the very important clue? The important clue is your synovial fluid examination. So you should be very much aware what is the shape of this particular negatively birefringent needle-shaped crystals. And if you don't know the shape of this particular uric acid crystals in the synovial fluid examination, then it becomes very difficult for you to answer these type of questions. Okay, so please keep this in mind. Next, right, so the another clinical based question, same related to your gout. You are planning on starting allopurinol for Miss Maggie for a new diagnosis of the gouty arthritis. Which of the following best describes appropriate dosing patterns or dosing strategies for allopurinol? Right, which of the following best describes the appropriate dosing strategies for allopurinol? First option, allopurinol and azathioprine are commonly used together in the treatment of gout. Second option, allopurinol dosing should be adjusted for the liver function. Third option, allopurinol dosing should be titrated to achieve a serum uric acid levels of less than 6. Fourth option, allopurinol should be avoided when patients are taking colchicine. Fifth option, allopurinol toxicity is more common in patients expressing HLA-B27. So the question is, which of the following is the true statement about your strategies of allopurinol in a case of ankylosing in a case of the gout or gouty arthritis. Yes, who will be the first person to answer this question? Any one of you? How will you approach the treatment of gout with allopurinol? Right. So let me take the, yes, anyone want to make an attempt? None of you are making an attempt of this question? Okay. Now let me just crack this question. Allopurinol and as well as azathioprine are commonly used together is a wrong statement. Both of them, they are not commonly used. Okay, so Khan Anjifa has opted for allopurinol should be avoided when the patient is taking colchicine. Is that okay? Let me take up. Now, allopurinol and azathioprine, they are commonly used together in the treatment of the gout. They are wrong statement. Okay, and allopurinol dosing should be adjusted for the renal function and not the liver function. Third statement. Allopurinol dosing should be titrated to achieve a serum uric acid levels of less than 6 milligrams is a correct answer. And you take the normal uric acid levels. Normal uric acid levels is 2 to 6 milligrams per deciliter. So whenever you are giving allopurinol, which is a xanthine oxidase inhibitor, right? What should be the level that has to be titrated? The serum uric acid level has to be titrated less than 6 milligrams per deciliter. That is an absolutely a true statement. Okay, and allopurinol should be avoided? No, it need not be avoided. Allopurinol can be comfortably given when the patients are already taking colchicine. So the fourth option is a wrong statement. And allopurinol toxicity is more common in patients expressing HLA-B27, right? So you don't have that. So allopurinol toxicity is not seen in patients expressing the HLA-B27. So HLA-B27, where do you come across? You will come across that in patients with the ankylosing spondylitis. Okay. So now you take this allopurinol. So what should be the target of the uric acid whenever you are giving allopurinol? The target of the uric acid should be less than 6 milligrams per deciliter. Right? Now, what is the dose that you have to start with? So initially, you can start this allopurinol 100 milligrams initially, and later you step it up. So how much you have to step it up? Please step it up to 800 milligrams if needed, right? And increase up to 800 milligrams if needed. Okay, so that is about the dosage of your allopurinol. But whenever you are giving allopurinol, always remember you have to check for the kidney function. If there is chronic renal disease, remember, you have to reduce the dosage of the allopurinol, right? The dosage of the allopurinol should be reduced if the creatinine clearance is decreased, right? If the creatinine clearance is decreased, okay? Next. So that is about your allopurinol. So what should be the dosage? Oh, sorry. Yeah, what should be the dosage? 100 milligrams you can start, and you can gradually increase up to 800 milligrams. Right, and allopurinol dosing should be titrated to achieve the serum uric acid levels of less than 6 milligrams per deciliter. So that is the correct answer to this question, right? Next. Now we will take up one more clinical based question. Yes, so this is another very interesting question, and let me see how many of you can crack this. A 36-year-old woman presents to your office with diffuse pain throughout her body associated with fatigue, insomnia, and difficulty in concentrating. So there is presence of diffuse pain all over the body, and there is fatigue, insomnia, and difficulty in concentrating. And she finds that the pain is difficult to localize, right? The pain is difficult to localize, but reports that it is around 7 to 8 out of 10 in the intensity of the pain. And this is not relieved with your NSAIDs. So there is diffuse pain. That is first point. And second point is this particular pain is not responding to your NSAIDs. Right? Not responding to your NSAIDs. Okay, right. And she has a long-standing history of generalized anxiety disorder and is treated with the sertraline, which is an antidepressant, as well as clonazepam 1 milligram twice daily. On examination, she has pain with palpation at several musculoskeletal sites. At several musculoskeletal sites, whenever you have palpated, the individual had found pain. Her physical exam, her laboratory examination demonstrate a normal complete blood count, basic metabolic panel, ESR, and the rheumatoid factor. So everything is within the normal limits. And you diagnose her with fibromyalgia. All of the following therapies are recommended as a part of the treatment plan for the fibromyalgia, except an exercise program that includes strengthening exercises and aerobic exercises. Second option, cognitive behavior therapy for insomnia, milnacipran, oxycodone, pregabalin. So what is the therapy that should be avoided for the treatment of your fibromyalgia? Anyone? So first of all, you should know what is the diagnosis. Diagnosis is fibromyalgia. Right? Diagnosis is fibromyalgia. So that point you are very much clear that diagnosis is fibromyalgia. But what is the therapy that should be avoided in case of fibromyalgia? Right? So diagnosis has been made very nicely depending upon the pain at multiple sites. But remember, in case of the fibromyalgia, there is no role of, right, very good, Khan Anzifa. The answer is oxycodone. Opioids, they have no role. Right? Opioids, they have no role in the treatment of your fibromyalgia. And not only here. Now, what is the treatment for the fibromyalgia then? And even your steroids are also avoided in fibromyalgia. Right? Steroids are also avoided. And the fibromyalgia being a psychological disorder which is more common in women rather than men. Right? This is more common in women rather than men. Now, this particular opioids, right? This particular opioids and steroids does not help in relieving the pain in patients with the fibromyalgia. So what does they require? They require the psychological counseling support. For that, a cognitive behavior therapy for insomnia, an exercise training program that excludes training, aerobic exercises, and as well as the yoga. Right? As well as the yoga. So these are the lifestyle modifications what we advise in a patient with the fibromyalgia. Then cognitive behavioral therapy. See, what do you understand by this word cognitive behavioral therapy? Cognitive behavioral therapy, it tells you that the individual has to reduce the anxiety, right? Should reduce the anxiety. And by giving the cognitive behavioral therapy, that will improve the sleep disturbance and that will also decrease the illness behavior. That will also decrease the illness behavior. So that is what is your cognitive behavioral therapy. Next, followed by that, the pharmacological therapy. See, pharmacological therapy in case of fibromyalgia, you have to target the afferent pathway and you should also target the efferent pathway. Now, what are your drugs? Pharmacological group of drugs. We have two classes of drugs, right? We have two most common categories of the medications for fibromyalgia. They include antidepressants and as well as the anticonvulsants. Now, what are those antidepressants? That includes amitriptyline, duloxetine, and milnacipran. And these all have found to be having some efficacy in fibromyalgia. But what has been approved in US FDA? It is your duloxetine and as well as milnacipran. These are the approved drugs by the US FDA for the treatment of the fibromyalgia, right? For the treatment of And remember, So these are the two group of drugs. One is your antidepressant and the other one is your anticonvulsant, right? Anticonvulsant. Now, the anticonvulsants, they are predominantly used in fibromyalgia are those that are ligands of alpha 2 delta subunit of the voltage gated calcium channels. Now, I said you that you need to give anti-epileptic also in these patients, right? So they include gabapentin and as well as pregabalin, right? They include gabapentin and as well as the pregabalin. And as already I've said you in the beginning also, that glucocorticoids, they have no role. Anti-inflammatory drugs, they have no role, okay? So anti-inflammatory medications and glucocorticoids, they are not effective in case of fibromyalgia. For suppose, if there is comorbid associative condition, right, comorbid associated condition such as rheumatoid arthritis, appropriate therapy directed at underlying disorder is critical to control the symptoms of fibromyalgia as well, okay? But remember, opioid analgesics such as oxycodone, they are absolutely avoided in this clinical scenario of the fibromyalgia. Why? Because there has no efficacy of your oxycodone in treating the fibromyalgia and may include hyperalgesia that can worsen both pain and as well as the function. Both pain and as well as the function. So these are some of the points related to your fibromyalgia. So fibromyalgia is a psychological disorder more commonly seen in males rather than, more commonly seen in females rather than males. And this fibromyalgia, they have non-specific pains all over the body, right? And the way how you can diagnose and how you can treat the fibromyalgia is cognitive behavioral therapy for insomnia is very important. Then you can give the other group of drugs which will reduce this particular neuropathic pain or fibromyalgia pain, that includes pregabalin. And psychological support is also very important, that is cognitive behavioral therapy for insomnia, right? So that completes the discussion on the topic of the fibromyalgia. And next important thing is, so these are the questions for today, right? So we have only half an hour session. I'll just quickly summarize what we have discussed. We have discussed 3 important clinical based questions today. Number 1, related to your gout or gouty arthritis. What is the take home message of this particular question? Take home message of this particular question is, in case of gout or gouty arthritis, you will have negatively birefringent needle shaped crystals on synovial fluid examination. That is the take home message of your gout or gouty arthritis. And if you take the treat, and in pseudo gout, you will have rhomboid shaped crystals, and most commonly affected joint in case of pseudo gout is your knee joint. And the most common joint affected in case of your gouty arthritis, that is your first MTP, first metatarsophalangeal joint. And the second question was related to the treatment of your gout. That is a take home message. So the treatment is the allopurinol. Whenever you are giving allopurinol, you have to ensure that the levels of the uric acids are less than 6 once you have started with the allopurinol. And alternative drugs of your allopurinol is your febuxostat, right? Alternative drugs of your allopurinol is your febuxostat, right? Now, the last question what we were discussing is about the fibromyalgia, which is a psychological disorder, right? And where the individual has been advised a group of medications and as well as the cognitive behavioral therapy. But one important point, right? One important point in these individuals with fibromyalgia, steroids are avoided and as well as the oxycodone, that is opioids, they are avoided, right? So thank you very much. So, right. So we will stop this session at this point. Tomorrow we will have 2 sessions, right? Because we have done only half an hour today. So tomorrow we will do an extra half an hour in order to replace this particular loss of half an hour, like what we are supposed to do today, right? So thank you very much and see you in the upcoming sessions.